Appendicitis is when the appendix gets inflamed, and it's the most common surgical emergency of the abdomen. Normally, the appendix can be found in a retrocecal location, as well as pre-ileal, post-ileal, pelvic, and subcecal. Since the appendix is a hollow tube, the most common cause of inflammation is something getting stuck in or obstructing that tube. That something could be a fecalith, which is a hardened lump of fecal matter, an undigested seed, or even intestinal parasites like pinworms. Another cause of obstruction, especially in children and adolescents, is lymphoid follicle growth, also called lymphoid hyperplasia. Lymphoid follicles in the appendix grow in size during adolescence, and they can sometimes obstruct the tube. Exposure to viral infections like adenovirus and measles can also cause these follicles to grow as well. Early on, acute appendicitis causes periumbilical abdominal pain, as well as nausea and vomiting. Sometimes there can be other atypical symptoms like indigestion, flatulence, diarrhea, and malaise. Within 24 to 48 hours, the appendix becomes more swollen and inflamed, and it starts to irritate the abdominal wall, causing the pain to get more severe and localized to the right lower quadrant, as well as causing a fever. This classic migration of pain may not be seen in children under 3 years old. McBurney's sign is tenderness at McBurney's point, which is located 1/3 of the distance from the anterior superior iliac spine to the belly button. And it's a classic sign of appendicitis. Another sign of appendicitis is Rovsing's sign, which is when palpation of the left lower quadrant causes pain in the right lower quadrant. The obturator sign is when the inflamed appendix lies in the pelvis and causes irritation of the obturator internus muscle. The iliopsoas sign is when there's pain on extension of the right hip, which is found in retrocecal appendicitis. Now, if obstruction persists, the pressure on the appendix increases even more, and the appendiceal walls become weaker and weaker, up to the point where the appendix might rupture. Perforation of the gastrointestinal tract allows bacteria to escape the appendix and get into the peritoneum. An important and early sign of peritoneal irritation is abdominal guarding, which is when an individual tightens their abdominal muscles during palpation to try and avoid pain. Blumberg's sign, also referred to as rebound tenderness, refers to palpation and quick release, with pain felt upon release of pressure, again a sign of peritoneal irritation. Diagnosis of appendicitis can be supported by laboratory tests. Typically, in blood tests, the white blood cell count is elevated with a neutrophil predominant, and there's an elevated CRP. Blood tests might also show dehydration or fluid and electrolyte imbalances. A urinalysis should be done to rule out genitourinary conditions as the cause of abdominal pain. Irritation of the bladder or ureter by an inflamed appendix might result in mildly elevated urinary white blood cell count, while a significant elevation suggests there's a urinary tract infection. In addition, to rule out ectopic pregnancy, postmenarcheal pediatric cases should get a urine pregnancy test, and adult females should obtain a serum pregnancy test. The surgical goal of appendicitis is to operate early, before appendiceal rupture and peritonitis develop. So individuals with classic findings might be taken for immediate surgery without imaging studies, while individuals with atypical presentation might need further testing to rule out conditions like bowel obstruction, ovarian or testicular torsion, and kidney stones. Plain abdominal radiography is not useful in making the diagnosis of appendicitis, and should not be routinely obtained. Ultrasound is the preferred first choice, while CT scan is done as follow-up if the ultrasound is inconclusive. MRI is recommended over CT scan in pregnant women and children who can cooperate, to minimize radiation exposure, but it often can't be done emergently. On ultrasound, there's usually an enlarged appendix with a diameter of more than 6 millimeters, as well as tenderness over the appendix with compression of the ultrasound probe. If there's an abscess, there might be increased echogenicity of the inflamed periappendiceal fat, and in severe cases there might be an appendicolith, which is a calcified deposit within the appendix. CT scan or MRI features of acute appendicitis include an enlarged appendix, an appendiceal wall thickening of more than 2 millimeters, periappendiceal fat stranding, appendiceal wall enhancement, and there might also be evidence of an abscess. The standard treatment for appendicitis is appendectomy, which is surgical removal of the appendix. Both open and laparoscopic approaches might be used. For an acute non-perforated appendicitis, an appendectomy should be done within 12 hours of diagnosis. Preoperative management includes intravenous rehydration, correction of electrolyte abnormalities, and administration of prophylactic antibiotics. Antibiotics should be administered as soon as the diagnosis of appendicitis is established, and at least 30 minutes before the surgical incision is made. Generally, individuals are given a single intravenous dose of 2 grams of cefoxitin or cefotitan, or the combination of 2 grams of cefazolin plus 500 milligrams of metronidazole. While individuals allergic to penicillins and cephalosporins might get clindamycin plus ciprofloxacin, levofloxacin, gentamicin, or aztreonam. Appendicitis is considered advanced when perforation or gangrene has developed. Individuals with unstable perforated appendicitis, meaning it's caused generalized peritonitis or hemodynamic instability, require emergency appendectomy, as well as irrigation and drainage of the peritoneal cavity. After surgery, individuals might be started on a clear liquid diet and advanced as tolerated to a regular diet. And might be discharged once they tolerate a regular diet and are afebrile. Postoperative antibiotics are generally only given to children with advanced appendicitis. And in that situation, IV antibiotics are continued until they can tolerate a regular diet and are afebrile. Children who are still febrile or unable to tolerate a regular diet 7 days after surgery might have an abdominal or pelvic abscess and should have diagnostic imaging studies done. Now, stable individuals with perforated appendicitis who have symptoms localized to the right lower quadrant, meaning there's no generalized peritonitis, should be treated with antibiotics and intravenous fluids, rather than immediate surgery. These individuals will often have a palpable mass on physical examination, and imaging studies might reveal a phlegmon, an area of local tissue inflammation, or an abscess. If there's a phlegmon, then individuals are kept on IV antibiotics and repeat imaging is often performed to follow the resolution or progression of the phlegmon, and to make sure that it doesn't develop into an abscess. On the other hand, if there's an intra-abdominal or pelvic abscess, then individuals are kept on IV antibiotics, and should have CT or ultrasound-guided percutaneous drainage. Immediate appendectomy is an alternative option if the abscess is not amenable to percutaneous drainage. Now, if individuals who didn't get immediate surgery fail initial antibiotic therapy, they require rescue appendectomy, whereas those who respond to initial antibiotic therapy can be discharged with oral antibiotics to complete a 7 to 10 day course and return for follow-up in 6 weeks. Alright, as a quick recap. Appendicitis initially causes nausea, vomiting, fever, and periumbilical abdominal pain that then migrates to the right lower quadrant. Classic signs include McBurney's sign, Rovsing's sign, the obturator sign, and the iliopsoas sign. If the appendix ruptures, it can cause peritonitis, which can cause abdominal guarding and Blumberg's sign. Typically, there's an elevated white blood cell count with a neutrophil predominance, and an elevated CRP. Ultrasound is the preferred first choice, while CT scan is done as follow-up if the ultrasound is inconclusive. MRI is recommended over CT scan in pregnant women and children who can cooperate. For acute non-perforated appendicitis, immediate appendectomy should be performed within 12 hours of diagnosis. Preoperative management includes intravenous rehydration, correction of electrolyte abnormalities, and prophylactic antibiotics. Stable individuals with perforated appendicitis who have a phlegmon of the right lower quadrant should be given IV antibiotics. Individuals with an intra-abdominal or pelvic abscess should be given IV antibiotics and have a CT or ultrasound-guided percutaneous drainage. Immediate appendectomy is an alternative option if the abscess is not amenable to percutaneous drainage. Those who fail initial antibiotic therapy require rescue appendectomy, whereas those who respond to initial antibiotic therapy can be discharged with oral antibiotics to complete a 7 to 10 day course.